Thank you so much, Dr. Bailey-Stanton. So like Dr. Bailey-Stanton said, my name is Anke, and today I will be presenting febrile seizures. This is actually quite an important topic, as it is a very common presentation that we see in the emergency department. And I'm not sure if all of you know, but not all febrile seizures require admission. And therefore, it's very important that we understand it and know what to look out for, and when it is safe to send the kiddie home, and when the kid should rather be worked up further. So to start off with, let me just get the slideshow to go. Okay, so first of all, what is a febrile seizure? So a febrile seizure is an event occurring in children between the age of 6 months to 6 years within 24 hours of a temperature that was above 38 degrees Celsius, and it is not caused by any central nervous system infection, any electrolyte abnormalities, metabolic abnormalities, or inflammation, without any previous seizures, including previous neonatal seizures, unprovoked seizures, or previous afebrile seizures, and not meeting the criteria for any other acute symptomatic seizure. So before I can continue, we must just go through a few more definitions to make everything more clear. So a fever is defined as an elevated core temperature above 37.5 degrees Celsius, which can be part of a defense response to the invasion of live or inanimate matter recognized as pathogenic by the host. So what is a seizure? A seizure is an involuntary disturbance of the brain function associated with a change in the level of consciousness, abnormal motor activity, behavioral changes, sensory disturbances, and autonomic dysfunction. So the normal inhibition is overcome by excessive excitatory stimuli in the brain. Then convulsions. So convulsions are medical conditions where the body muscles contract and relax rapidly and repeatedly, resulting in an uncontrolled shaking of the body. So when you have multiple of these, then you get epilepsy. So it's a brain disease characterized by at least 2 unprovoked seizures, more than 24 hours apart, or it can be a diagnosis of a known epileptic syndrome, or if you have 1 unprovoked seizure with the probability of a further seizure over the next 10 years. And then status epilepticus, that is when you have a prolonged, self-sustaining seizure or repeated seizures without return to your baseline. So what's the epidemiology of febrile seizures? So it's important to know febrile seizures are the most common neurological disorder in this age group. It affects 2 to 5% of children. It's predominantly caused by viral infections. It's most common in the age 18 to 22 months. There's a slight male predominance, and it occurs equally in all races. So the pathophysiology of febrile seizures. So in children in this age group of 6 months to 6 years, the seizure threshold is very low. And as we know, children in this age group are very susceptible to infection. Sorry, I just want to remind you guys to please mute yourself. Thank you. Okay, sorry. So I'm going to continue. So the pathophysiology. So when a child gets a fever, then it triggers the seizures by increasing the core temperature, making the neurons more excitable. Children also hyperventilate as a result of the fever and from crying from being ill, which causes respiratory alkalosis, also contributing to more excitable neurons. And then in response to the illness, your immunity releases cytokines. These cytokines increases the NMDA receptors, which also increases your seizure probability. So there are a few risk factors to getting febrile seizures. So firstly, it's when you have high fevers, having an infection in that age group of 6 months to 6 years, family history of febrile seizures, children attending daycare, as we know that's a hub for all infections, then maternal alcohol and smoking use during pregnancy, a child with developmental delay, and then also if the child was admitted after birth and was only discharged after 28 days of life. Then there are some important risk factors for recurrence. So the first risk factor is if your first febrile seizure was at a very young age. Secondly, if you have a low fever with the first febrile seizure, say for instance it was 37.8 and then you had a febrile seizure. Then if you have a first degree family relative that had febrile seizures, if there was a short time period, between the fever onset and then your febrile seizure, and if you have one or more seizure, if you have more than one seizure during your first episode of febrile seizures. So importantly, if you have 4 out of these 5 risk factors, then you have a more than 70% chance of recurrence of a febrile seizure. So we get different types of febrile seizures, and this is quite important for determining if it is safe to send a kiddie home or not. So we have simple febrile seizures, complex febrile seizures, and then febrile status epilepticus. So our simple febrile seizures is generalized tonic-clonic seizures that lasts less than 15 minutes. It self-aborts. It doesn't recur within 24 hours, so you have a single episode. There's no neurological deficit after the seizure, so the child completely returns to baseline. And if these factors are present, then usually the child has a very good prognosis. Then we get complex febrile seizures. It can either be generalized tonic-clonic seizures or focal seizures. It lasts more than 15 minutes. It comes in clusters of 2 or more in 24 hours. If the child have post-ictal symptoms and neurological deficit, or prolonged post-ictal period. And it's important to know that this can progress to febrile status epilepticus, and it may indicate a more serious disease process. So just to note that a complex febrile seizure doesn't have to have all of these criteria. It can have one of them, and then that makes it a complex febrile seizure. And then status epilepticus can occur, so like I said earlier, it is if it is prolonged seizures or if it's recurrent without returning to baseline. And this usually lasts more than 30 minutes. Okay, so the clinical presentation of febrile seizures. So first, we have to look at the history. So what is important questions to ask the parents when they bring in a child saying that the child had a fit or a seizure or was shaking? Any volunteers? Anyone?
Can start with, what is the duration of the fit? Was it witnessed? Was it the whole body shaking or just one side? Has the child ever had a fit before? Did it spontaneously abort, or did EMS have to give any medication or anything to abort it? Has the child been ill preceding the seizure?
Yes, okay. Thanks, Amy. That's very good. So you first of all want to determine, was this really a seizure or was this not a seizure? And therefore you must ask, was this the whole body shaking? Was the child responding during this time, or had the child had any altered mental state? Was there foaming of the mouth, eyes rolling back, or fixed gaze, or difficulty breathing? Then it's important to note the duration. It's important to note the history of the fever and duration of the fever. Any preceding illness, signs and symptoms are important. And then it's important to ask the mom or dad or caretaker if this ever happened before. So any history of previous seizures, if there's any developmental delay or any known neurological conditions. And then it's also very important to ask about trauma history and ingestion history. Okay, so then if you've established that, okay, this was in fact a seizure, then we go on to examination. So what are the key features that we are going to look for on physical examination?
Anke, it's Leslie speaking.
Hey, Les.
On examination, first you want to take the child to a resus bed and do an ABCD approach, just to make sure that our airway and our emergency treatment is initiated. But then on a more focused examination, we want to try elicit if there's a source of infection. So a thorough ENT examination, also checking for any meningism. So literally I usually do it from head to toe. So thinking of brain, what could go wrong in the brain, that infections that could cause the seizures or cause the fever and then cause the seizures. And then ENT, CVS, respiratory, lower respiratory tract infections, and abdomen, and also looking for any rashes on the body.
Yes, very good. Thanks, Leslie. Yeah, so the focus of your examination should be to look for an underlying cause of the fever, what's causing the child to have a fever. And always remember to do the ENT exam, because sometimes it is a otitis media that is hiding there deep inside. Okay, so then we look at causes and basically more of a diff diagnosis. So in ED, we usually want an approach of the life-threatening causes. We want to rule them out first. Then you want to look at common causes, and then we go to the rare causes. So life-threatening causes of seizures will definitely be CNS infection, so meningitis, encephalitis. It can be a space-occupying lesion if the child is having focal seizures. So that's always important to rule out the life-threatening causes first. Then we look at the common things. So other things that can also occur commonly is children getting rigors. So that would be shaking without a loss of consciousness. And then it can also be evolving epilepsy syndrome. Because remember, fever lowers your seizure threshold. So it can be that the child has an underlying epilepsy syndrome, and because of the fever, the seizure threshold is lower, and now the child's having a fit or seizure. And then you get some rare things, which I've actually never seen myself, but we get febrile delirium. So that's a high fever triggering an acute transient confusion state, breath holding attacks, and then febrile syncope. Okay, so next on we go to the management, and Leslie is one step ahead of me here. So as we know, it's the ED, it's always the life-threatening stuff first. Always you want to start with the ABCDE approach. And remember that all of these things that I'm going to discuss mostly they happen simultaneously. So if we say A, B, C, D, E, you don't start just looking at the airway and doing that or the breathing. You assess the child as a whole, and then you address the problem as you identify them. But in broad, I'm going to go through all of these things individually as well. But in broad, you want to start with the ABCDE approach. Then you want to abort the seizure if the child is still actively seizing. Then you want to investigate for an underlying cause. You want to treat the underlying cause. And then you want to do neuro observations if they are indicated, and refer to pediatrics if they are indicated. So if the child is actively seizing, we're definitely taking them to a resus bed. We're putting them in the recovery position, which is the left lateral position. And then we go via the ABCDE approach. As you identify a problem, you're going to address that. So just for the interns that are also online, so just a quick recap. So under airway, you're going to look, is the airway patent and maintainable? And you're going to secure the airway if need be. You're going to look, in breathing, you're going to look at the rest rate, the effort, is the chest expansion and the air movement. And then you're going to also do oxygen saturation and give some supplemental oxygen if needed. Under circulation, it's important to look at the heart rate, the rhythm of the rate, the pulses, the cap refill, skin color and temperature, and the blood pressure. So obviously when a child is actively seizing, you're not going to try and put a BP cuff on and do that, try and get the blood pressure reading. So the more you patients you see like this in the ED, the more comfortable you get in when to do what and how to do these things simultaneously and address the most critical or the most important things first. Okay, then under disability, you usually look at we use the AFPU score. So is the child alert, responding to verbal cues, pain, or is the child unresponsive? Then you also want to look at the papillary response of the child. Then is there any evidence of meningeal irritation? Then something very, very, very important in seizing children is you want to do the HGT to make sure that this fit is not because of a hypoglycemia. And then you want to expose the child fully. So you undress the child, you do the temperature, you look for rashes or any signs of trauma. Okay. So once you've addressed the ABCDEs, then you want to abort the seizure. So as you guys know, it's not always possible to get IV access in a fitting or seizing child. So I'm giving options of when you have IV access, what drugs and dosages to use, and when you don't have IV access. So when you have IV access, then you can use lorazepam 0.1 milligram per kg or midazolam 0.25 milligram per kg, which is the one that we have in our ED, is the midaz, or then diazepam 0.2 milligrams per kg. If you don't have any IV access, then you can use lorazepam, same dosage, 0.1 milligrams per kg, either IM or buccally. Midazolam 0.5, so you double that from the IV dosage, so 0.5 milligrams per kg, buccally or intranasally, or IM, or diazepam 0.5 milligrams per kg per rectum. So yeah, correct me if I'm wrong, but I think our first line in Rahima Musa ED is the midazolam that we use. And then it's in that particular order because that's also the quickest onset versus and the quickest offset is lorazepam, then midaz, then the diazepam. Okay, so once you've aborted the seizure and you've stabilized this child, now you must decide, what am I going to do further? So what workup is necessary for a child with febrile seizures? Can anyone take a guess? Or let me ask, is routine lab studies indicated for every child with a febrile seizure?
Anke, it's Amy.
Yes.
My understanding is that if you have a simple febrile seizure and you have an identified or confirmed source of febrile illness that caused it, then routine workup is not necessary. Normally we in the ED will do a gas just to make sure there's no electrolyte disturbances and an ECG, but I don't know if the literature and stuff says that that's absolutely necessary for simple febrile seizures. For complex febrile seizures, I think they do need further workup. And then one other thing that I actually wanted to ask is, when I did internship, I remember it being said that for all children under 2 years old, they need a full workup, including an LP, because they don't have, or they don't elicit typical signs of meningism, but I don't know what the actual evidence is on that. I don't know if you read anything about that.
Okay, so yes, you are correct. If it is a simple febrile seizure and you have a clear source of infection, then you don't need to do any routine lab studies. So then it's not indicated. And remember that usually, or most of the times in our ED, the children present long after the seizures. So if the child is actively seizing and now is very sleepy, then I would understand to do a gas on everyone. But if it's a child that had a febrile seizure 6 hours ago and has been 100% fine since then, is running around in our ED, eating a lollipop, and is a happy child, settled after the Panado, then we don't need to do a gas for each and every child. So you only do the lab studies if you are looking for a source of infection, or if you want to rule out electrolyte abnormalities, then you can do a VBG and some basic bloods. Then the literature that I've read said that LPs are not routinely done if there is a clear source of infection. So if you can't find a clear source of infection or clear cause of the seizure, then an LP is indicated. But if you now see there's a roaring otitis media, then you don't need to do an LP on the child, regardless of the age. But if it is a complex febrile seizure or you are uncertain about the diagnosis, then it's said to consider an LP, not to definitely do it. So I think it's advisable to then get the pediatrician's input on what they think about it if you're unsure. Then the literature also said that no imaging is indicated. And if you are suspecting another neurological condition, then you should consult expert advice. So yeah, no routine lab studies are indicated unless if you don't know the source of infection or if you are expecting it to be from electrolyte abnormalities, and then just to repeat that the LP is not routinely done if you have a clear source of infection. If not, then you can consider the LP. Okay, does that answer your question?
Yes, thank you.
Okay. So, then another big question. When the seizure is aborted, your child is stabilized, should everyone get Panado? Is my first question. And second question is, does antipyretics prevent further seizures?
It's Amy again. Dr. Rubinson, I think, did a talk last year where they said that actually if the child is not symptomatic from the fever, in other words, they have a fever, but they fairly happy and, you know, they're not miserable from their fever, then we actually shouldn't be treating every fever with antipyretics. It doesn't make any difference. And I think in ICUs, they showed that the giving antipyretics increase the minimum inhibitory concentration. So we don't have to treat every single fever if the child's not symptomatic of it. And I don't think that it increases the chance of another fever, of another febrile seizure, if the fever is not treated.
Yes, so well done. Antipyretics does not prevent another seizure from occurring. It's only symptomatic to comfort a child that's irritable and miserable. So the most important thing in your further management is to treat the underlying cause. So
can I chime in here, Anke?
Yes.
So it's Tammy speaking. All right, so we know that giving antipyretics doesn't prevent a febrile convulsion. How does using an antipyretic actually affect the body's immune response or capacity to react to an infection?
So I want to take a wild guess here. But if the antipyretic is decreasing the fever, which is part of the normal immune response, then I assume it is, I want to say not lowering the immune response, but it is suppressing it a little bit.
Yes, so okay. So everybody's terrified of fevers, but part of your body's immune response is to have rubor, so to have redness, to have an increased capillary refill and increased capillary flow in the area, to have increased inflammatory cells mopping up the infection and targeting the infection. So it is one of the reasons why you'll often find intensivists, pediatricians, internal medicine specialists don't like us to just routinely treat a fever. If a patient has a severe earache with a fever because of their infection, sure, you can give them some paracetamol for pain, some ibuprofen for pain. If they are having really bad rigors and a headache, we can definitely give them something to help for the pain. So it's just a different way of thinking about things. Why do we want to suppress the body's natural immune response? And it is a natural thing to mount a fever when we are trying to fight an infection. Patients that have really high temperatures, for example, patients with malaria, we won't use hectic antipyretics. They've got an excruciating headache. They'll get a bit of Panado for the headache. If they've got myalgias, maybe some Panados for the myalgia, but it's not specifically the fever that we're treating. So it's just reframing the way that we're thinking about things.
Thank you. Okay, so yeah, not all kiddies with the febrile seizures need the antipyretics. So if you have a child with a simple febrile seizure with a clear cause of infection and a child is in a good clinical condition with no other admission criteria, then you don't need to do further workup and admission, and the child can be discharged from the ED after appropriate observation. So who then needs admission? Wait, I'm missing. Yeah, who then needs admission? If I'm telling you that the child has no admission criteria and doesn't need further workup, then they can be discharged. So then how do we determine which patients we can send home and which patient needs to stay? You have to look at red flag signs. So yeah, I've put together some of the important red flag signs. So red flag signs, first of all, on the history, there'll be some things that are red flag signs. So if it was a complex febrile seizure and it is recurrent, or the child's not returning to baseline, or there's other signs that might indicate some meningeal infection or encephalitis or something like that. If there is any suspicion of another neurological condition, so if they have lethargy, irritability, loss of appetite, vomiting, then on clinical examination, a stiff neck, photophobia, a depressed level of consciousness, if they have any focal neurological signs, if they have a bulging or a tense fontanelle, or if in the bit older children, if they have a positive Brzezinski or Koenig sign. Then if it is a complex febrile seizure, or more than one seizure in 24 hours, if there was a prolonged post-ictal state of altered level of consciousness. So prolonged post-ictal will be more than 1 hour of the lethargy and the altered level of consciousness. Then if the child has an incomplete immunization chart, then you must usually look at the immunizations against Streptococcus pneumonia, and then also the HIB, the Haemophilus influenza B, especially in children 6 to 18 months. Then if the child has any neurocutaneous stigmata that can maybe alert you to a meningococcal meningitis, or if the child is clinically unstable. These are all red flag signs which should alert you to not send this child home from the ED. So these children you'd send across probably towards 17. So then to prevent any further febrile seizures, we don't routinely put them on antiepileptics. The risks of the medication of antiepileptics far outweighs the benefits of giving the antiepileptics for febrile seizures. So the only way you can prevent further febrile seizures is to do proper counseling and education for the mothers. So there's no let me rephrase. There's no proper prevention. So the only thing you can do is to counsel and educate the parents properly on the condition, on causative things that cause the febrile seizures, and then to educate them on what to do if the child gets a seizure at home. So important things to counsel them on is to tell them to protect the child from any injury during the seizure. So they must, if the child's high on a bed or on a couch, they must preferably put them on a flat surface where they can't fall off or can't hit their head against something. They should not restrain the child or put anything in the child's mouth. They should place the child on in recovery position. It's important for you to explain to them that the child may be sleepy for up to an hour after the seizure, but longer than that we are worried about. You must counsel them and say if the seizure lasts more than 5 minutes, then they should seek medical attention in the quickest route possible, whether that would be for their own transport or to wait for EMS. And then you must counsel them on antipyretics to comfort the child, and that there's no role in undressing or cooling a child externally. So putting a child in a bath or I've had a child come in with febrile seizures and they threw a bottle of vinegar over the child to stop the seizure. So stuff like that, you must counsel the parents on properly on how can they manage this child at home, and that they when they should be concerned and when they should bring the child back to the hospital. Okay, so this is our very nice protocol that we have in our ED, and it's also in our ED protocol, the big black book that we always have there on the desk. It basically summarizes everything. So if you're in the ED, have a look at it, take a picture on your phone to have it with you. It's a really good one. And yeah, that is it. These are my references. So